I'm pleased to welcome you to our webinar today. As director of the newly designated Parkinson's Foundation Center of Excellence at the VCU Parkinsons and Movement Disorders Center, located in Richmond, Virginia, it's important to me to keep our Parkinson's patients and our greater Parkinson's community informed and connected. This webinar is one of many in a series that explores important and timely topics in Parkinson's disease. As usual, we will start out with a panelist interview and we will save time at the end for questions and answers. If you'd like to share this information with a friend, know that we're recording this webinar and we will distribute it via email after the session is over in the coming days. Today's topic is autonomic symptoms in Parkinson's disease. Today's session is made possible by a grant from the Parkinson's Foundation and also by our wonderful partners who are joining us today, Gary Rogliano and Margaret Preston from Power Over Parkinson's. Since 2019, we've partnered together on things like this webinar, but also more broadly to improve the lives of people living with PD through exercise and wellness programs, as well as socialization activities and peer-to-peer support programs. Gary and Margaret are here with us today. So could you take a moment and describe a little bit about POP's mission and some of the things that you offer to our local Parkinson's community?
Sure. Good afternoon. I'm Margaret Preston, the president of Power Over Parkinson's. And for those of you who don't know about POP, Power Over Parkinson's, we started about 4 years ago in partnership with VCU Health and the Parkinsons and Movement Disorder Center to support those with the disease. About 4 years ago, my father, Gary, was diagnosed with the disease, and we quickly sought ways to assist in his daily management of the disease, and ultimately founded Power Over Parkinson's to help others with their day-to-day management of the disease, wellness, socialization, education through seminars such as this. So really focus on the day-to-day living with the disease, and really with a big emphasis on exercise and wellness. So some of POP's core programs are, of course, our exercise program at Gold's Gym. That includes yoga, PWR moves class, and we are now taking over a dance class on the south side of Richmond. So we've got a little bit, something for everybody, hopefully, and all of that information can be found on our website. And I'll turn it over to my dad, Gary, for
Thanks, Margaret. For those of you who are not aware of POP, I encourage you to go to our website, poweroverpd.org, to learn more about our services and events. And now we're anxious to get started, so I will turn it over to Dr. Cloud.
Thanks, Gary. So once again, as a reminder to our participants, we welcome you to submit questions to us throughout the program, and we'll answer as many of them as we can at the end. If you want to ask an anonymous question, please use the Q&A feature in the Zoom toolbar at the bottom of your screen, and we'll get to as many as we can. So without further ado, let's get started. Dr. Cameron Miller-Patterson is our panelist today. So Cameron, welcome. Can you start out by telling our participants a little bit about your educational background and your current role at VCU Health?
Of course. So I'm a neurologist, and I received my fellowship training in movement disorders and Parkinson's at the University of Pittsburgh. And while there, in addition to seeing patients, I also was involved in a research project with another neurologist looking at whether particular autonomic symptoms are associated with how Parkinson's disease progresses in terms of how the motor symptoms progress. And so after I was done with my fellowship, I went to Penn in Philadelphia to get a master's degree, and I continued similar research. And then when I finished that a couple of months ago. I joined the VCU team in the beginning of September. And as faculty here, obviously I'm going to be seeing patients, but I'm also hoping to continue some of the autonomic dysfunction research that I had started back when I was a fellow.
And the VCU team is super happy to have you, so welcome.
Thank you.
All right, so why don't we start with the basics? So tell us a little bit about the autonomic nervous system. What is it, and what does it do under normal circumstances?
Yeah, so the autonomic nervous system is the part of the nervous system which includes parts of the brain, the spinal cord, and the nerves coming off the brain and spinal cord that helps to control the function of other organ systems in the body. So as an example, the nerves coming off the autonomic nervous system help to control heart rates. They help to control blood pressure. They help the GI tract, like the stomach, to digest food, and they help with other functions like sweating and then urinary and sexual function. In people with Parkinson's disease, the nerves coming off the autonomic nervous system and sometimes the parts of the autonomic nervous system and the brain and spinal cord aren't working appropriately. And so they can have a number of different symptoms. There are different symptoms that occur at different stages of Parkinson's disease. So constipation tends to be an earlier symptom. It can even occur decades before people have a diagnosis of Parkinson's. And then other symptoms like cardiovascular dysfunction, which we'll talk about in a little bit, like changes in heart rate and blood pressure, can sometimes occur early, but more often are more of a later feature of disease.
Thank you. So just how common are these autonomic problems in Parkinson's disease? Does everybody have them? Is it something that only affects a few people? Tell us a little bit more about that.
Yeah, so most people will experience some autonomic symptoms over the course of the disease. So the vast majority of people, for example, will have constipation, and this can be a very early symptom. Many people will have blood pressure changes, which can occur early, but more often occur in middle or later disease. So the vast majority of people with Parkinson's will have at least one autonomic symptom, whereas many people have several autonomic symptoms.
So why don't we focus in on a few of those more common symptoms? And I guess we can start with the cardiovascular ones. So problems with blood pressure regulation are extremely common in PD, as you said. And so I'd like to take a few minutes and talk about both neurogenic orthostatic hypotension and then also neurogenic supine hypertension. So lots of big words, but why don't we start by having you explain what orthostatic hypotension is and what types of symptoms it can cause?
Yeah, sure. So orthostatic hypotension is an inappropriate drop in blood pressure when a patient with Parkinson's disease changes position. So for example, when you go from lying down to standing up or from sitting in a chair to standing up. And this has to do with the fact that the nerves that are going to those blood vessels or to the heart aren't functioning properly. And so one of the major symptoms that occurs is lightheadedness or dizziness. And then if the orthostatic hypotension is very severe, some patients will even lose consciousness or syncopize. And this can obviously be dangerous because it can lead to falls and lead to injuries.
Yeah, and I will add to that I think it's important to remain very suspicious of the possibility that you might have orthostatic hypotension, because some people don't present with that very classic, I feel dizzy, or I feel like I'm going to faint, I feel lightheaded. Yeah. Sometimes it's more subtle than that. Like, sometimes when I stand up, I feel like I get a headache or pain in the back of my neck. And so the symptoms can be very subtle. And so it's something that as, movement disorders neurologists, we're always suspicious of
Absolutely.
that
Yes.
possibility.
Yes.
Okay, great. So tell us a little bit about how you approach treating orthostatic hypotension when it's a problem.
Okay, so I think one important thing to point out is that when we're treating orthostatic hypotension, what we're really focusing on are the symptoms and improving the symptoms, things like lightheadedness, that sort of pain that can occur around the neck, or even syncope. And we're not necessarily chasing blood pressure readings. So a lot of people with Parkinson's will have a little bit of a drop in blood pressure. Some may have more of a drop in blood pressure, but what we're really targeting is whether or not the patient is experiencing symptoms of orthostatic hypotension. And so one of the earliest things before we even start thinking about adding on new medications is we think about what are some simple lifestyle changes or conservative measures that we can incorporate that can make a difference. So I think one of the first things that we often do is we'll look at the patient's medication list to see if maybe there are some other medications that could be contributing to orthostatic hypotension, things like blood pressure medications, certain pain medications like opiates. And so sometimes this will be a conversation with the patient's other doctors, like their primary care doctor or cardiologist, to see maybe if some of these medications can be reduced or changed or eliminated. Obviously, we understand that a lot of times that's not possible because patients often need to be on these medications for other things as well. Another simple thing that we can look into is looking at lifestyle, things like dietary changes. Certain medication, or rather certain things like alcohol and caffeine can be dehydrating, and this can worsen orthostatic hypotension. Things with a lot of carbohydrates, like very sugary items, can drop blood pressure, especially if you've had a big meal, because the blood vessels around the gut dilate, and this can cause orthostatic symptoms right after a very big meal. So we often also recommend having smaller, more frequent meals throughout the day, as opposed to a couple of really big meals, which can induce those orthostatic symptoms. I think another big theme, which we'll see with a lot of the other symptoms, is the importance of physical activity. The reason for this is that people who are physically inactive, especially people with Parkinson's disease, can become deconditioned, and this can worsen the blood pressure changes. One of the issues here is that this can be a vicious cycle where people who have a lot of orthostasis have trouble tolerating exercise because they become very lightheaded, and then they become more deconditioned because they're physically inactive, and then they have more trouble engaging in exercise because of the orthostatic symptoms. So one way that often helps to get around this is to recommend exercise programs that don't induce the orthostatic symptoms. So I'll often recommend using exercise bikes, like a recumbent stationary bike or a rowing machine, which allows the patient to lie back and they don't have to get up, which can induce the orthostatic symptoms. Aquatherapy, like water therapy, can often be very helpful because the buoyancy of the water doesn't lead to the same drops in blood pressure as if you were out of the water and running around or doing other physical activities. So again, exercise is extremely important, especially early on. There are a couple of simple devices like compression stockings, which are tight stockings that you can wear around the ankles and calves. There's also abdominal binders, which you wear around the stomach. And what these essentially do is they squeeze the blood vessels to prevent your blood pressure from dropping when you're changing position. For some patients, they can be a little bit uncomfortable. Sometimes putting on the stockings can be tough for people with Parkinson's because of the issues with mobility. But if patients are able to use these, it's something that we often try to recommend before going on the medications. And then finally, if all those more conservative measures don't help or help a little bit, but maybe not enough, then at that point, we end up thinking about adding on medications that actually raise blood pressure. I know there's a couple of different medications here. Some of the medications, what they do is they retain water. So you're not losing as much water through urination. And so this helps to keep your blood pressure up. And then most of the other medications, what they do is they essentially take over the role of the nerves of the autonomic nervous system that aren't working as well anymore. And they keep your blood vessels constricted. And this also keeps your blood pressure up when you're doing things like changing position and physically active. These medications can have different side effects. Some of them raise your blood pressure. Some of them can cause lab abnormalities. So obviously when your doctor's prescribing these medications, they'll warn you about those, and they may have you check some labs every once in a while at follow-up visits, or they may even have you check your blood pressure at home.
All right. Thank you for that thorough answer. So now, in contrast to orthostatic hypotension, tell our audience about supine hypertension.
Yes. So supine hypertension often goes along with orthostatic hypotension. So it's another feature of cardiovascular dysfunction. And what this is an inappropriate rise in blood pressure when you're lying down. So for example, when you lie down to go to sleep. So in most people, when they go to lie down to go to sleep at night, there's a blood pressure dip, so your blood pressure goes down. But in people with Parkinson's disease, especially people who have orthostatic hypotension, they often have supine hypertension where they get something called reverse dipping, where their blood pressure actually goes up when they go down to go to sleep.
Okay. And so what can be some of the symptoms, practically speaking? How might someone know that they might have supine hypertension?
Yes. So one of the symptoms is that that high blood pressure can make you have to get up and go to the bathroom frequently at nighttime to urinate. So urinary dysfunction is another feature of Parkinson's, but having high blood pressure throughout the night can actually make you have to get up and urinate a lot. A lot of the times, though, supine hypertension, just like essential hypertension from atherosclerosis, which you see in a lot of people in general, even without Parkinson's disease, a lot of times it can be asymptomatic, so it doesn't cause any symptoms. There's some research looking into this. It's not clear if supine hypertension has the same risks as typical essential hypertension, but we do worry about things like potentially kidney injury, or increased risk of things like stroke or heart attack if you have excessively high blood pressure every time you go to sleep. So it is something that we want to look out for, especially if we already know that you have orthostatic hypotension. It's something we like to check for. And then if your blood pressure does become very high, it may be something that we want to address and treat.
And so that's perfect segue into my next question, which was, how do you go about treating supine hypertension?
Yes, so I think similar to orthostatic hypotension, we like to think about simple things that we can do before we necessarily add on more medications. So one of the things is, like I mentioned, a lot of people with supine hypertension have orthostatic hypotension, and so they may be on medications for orthostatic hypotension already. So we like to say, okay, you have to take this medication during the day, but don't take it right before bedtime. Take the last dosage at least a few hours before bedtime. Because if you do, because what these medications do is they raise your blood pressure. So if you take it right before bed, then that can actually contribute to raising your blood pressure. So if you have to be on those medications, make sure you don't do it right before bed. On that note, usually when I prescribe these medications, I usually like to know what the patient's blood pressure is both before and after starting the medication. So if I start them on something like midodrine or fludrocortisone, which are some of those medications for orthostasis, then I'll make sure that they have a blood pressure cuff at home, and I'll usually like them to check their blood pressure right before and then right after starting the medication to make sure that it's not going too high. And then I'll usually check in with them to see what their blood pressure readings are after the visit. Another simple thing is keeping the head of the bed tilted up a little bit, about 30 or 45 degrees. This can be done with things like pillows or a foam wedge, although sometimes having like an electric mattress can be really helpful because you can ensure that you're maintaining that elevation at nighttime. And if all else fails, if those simple measures don't work, we can talk about maybe adding an antihypertensive medication at nighttime. So as opposed to a medication that raises blood pressure like orthostasis, like for orthostasis, we may recommend trying a medication that lowers your blood pressure. Oftentimes we won't necessarily prescribe these ourselves. We might check in with the primary care doctor or the cardiologist and have a discussion with them. And usually these medications, if it's for supine hypertension specifically, will be prescribed right at bedtime. With that being said, when we do start these medications, it is often good to note that because it's dropping your blood pressure, it can actually exacerbate orthostasis. So if you're getting up to go to the bathroom, that's something you have to be careful about. And so it may also be good to have, say, a urinal next to the bed so you don't have to walk all the way to the bathroom, rather.
So it sounds like things can get pretty complicated between, medications to prevent the pressure from dropping when people sit up or stand up during the day, and then possibly medications at bedtime to keep the pressure from going too high when people are laying flat. So, that I can see how, that could potentially feel a bit overwhelming for patients, especially with having to record numbers. So, So I am going to now turn it over to Margaret. Margaret's going to talk to you a little bit about some of the GI manifestations of autonomic dysfunction.
Yeah, Dr. Miller-Patterson, as we jump into the GI symptoms, what are the most common gastrointestinal symptoms, autonomic symptoms associated with Parkinson's disease?
So Parkinson's, so the autonomic nervous system in Parkinson's disease, any part of it affecting the entire gastrointestinal tract can be affected. So anywhere from the throat and the esophagus all the way down to the stomach and the colon and the rectum. So there's a large range of symptoms that can be affected in people with Parkinson's. So one of them is dysphagia, which is another word for just trouble swallowing. And so this can often manifest as feeling like food is getting stuck in your throat when you're trying to swallow food. It can be choking or coughing even. And so one of the risks of this is aspiration, where food goes from your throat and then potentially down your trachea, down the other pipe into your lungs, and that can sometimes be dangerous. So that's something that we often want to look out for. Another feature of that trouble swallowing that many people with Parkinson's experience is drooling. And this is because people with Parkinson's have more trouble swallowing their saliva, swallowing their secretions. And so it ends up building up in the mouth. So it's not that people with Parkinson's are producing too much saliva, it's that they have trouble swallowing the saliva that's in their mouth. Another feature going kind of down the gastrointestinal tract is issues with the stomach. So gastroparesis is an issue with the stomach functioning properly, and it leads to something called delayed gastric emptying. So it doesn't push out food to the small intestine as quickly as it does in somebody who doesn't have Parkinson's disease. And this often leads to symptoms of nausea and bloating, especially after very big meals. And then going down, further down the GI tract to the colon, another symptom is constipation. So this is just because the colon is having more trouble pushing food out of the body, and so it tends to sit there, gets very dry, and then this of course leads to constipation. I think just one other thing that's important to add is that many of these symptoms are very common, things like constipation. So you can see them in the general population, and they're even people who don't have Parkinson's disease. But I think the point is that these symptoms tend to be more common in people who do have the disease.
So aside from, of course, being troublesome in and of themselves, do some of these symptoms, or can some of these symptoms lead to more PD complications or outcomes, such as, let's say, the absorption of Parkinson's medication? So can you kind of explain if some of these lead to additional issues down the road?
Yeah. So gastroparesis in particular, so issues with the stomach, the delayed gastric emptying, can lead to issues with medication absorption. So levodopa, which is carbidopa-levodopa, or Sinemet, which is one of the main medications we use in Parkinson's, is absorbed in the small intestine just after the stomach. So the stomach is pushing food and medications into the small intestine. And so that delayed gastric emptying, because it's not reaching the small intestine effectively, can lead to delayed effectiveness and motor fluctuations. And so that can affect the motor symptoms of Parkinson's as well.
If I can elaborate, you had noted drooling and swallowing. Could there also be dental complications associated with that as well?
Yes, so there can certainly be dental caries and dental issues with Parkinson's disease. So that's certainly another feature that can be associated with the excessive drooling that occurs with Parkinson's.
Yeah, okay. And then of course the million-dollar question is, can these GI symptoms be treated effectively?
Yes, so as with a lot of the other autonomic symptoms, it's all symptomatic management. So I guess starting from the top again, thinking about dysphagia, if patients are reporting a lot of trouble swallowing, one of the things we'll recommend often is that they see a speech therapist for a swallow study. And the reason this can be helpful is because the quality of the swallowing dysfunction can tell us if they may benefit from having a modified diet. So for example, adding liquid thickeners to their diet, which can prevent aspiration and choking. For the drooling, like a lot of other things, we tend to like to start with the simpler things before adding on medication. So something right up front I'll often recommend is to purchase sugarless gum or candy because that can soak up some of the saliva and reduce the drooling. Another pretty simple medication is just atropine drops, typically used for the eyes, but they can also be used in Parkinson's as well. So you just can add a drop under the tongue, and then this reduces saliva production and can reduce the drooling. There's also Botox injections into the salivary glands around the jaw, so near the cheeks, and then under the jaw as well. And that also reduces saliva production. And then there are also pills, oral medications that you can take as well. These can be very effective. Sometimes they can have side effects. For example, they can worsen constipation, they can cause dry mouth, dry eyes. And so if necessary, we can add these on, but it's something to be aware of that it can have some of these side effects. For the stomach symptoms, like I mentioned, having a really big meal in addition to exacerbating orthostatic hypotension can also cause the nausea and bloating from the delayed gastric emptying. So the smaller, more frequent meals also helps with the nausea and bloating and heartburn kind of symptoms too. You can consider medications. There are oral medications that help the stomach to push out food more effectively and more quickly. One important thing to point out here, though, is that a medication called Reglan or metoclopramide, which is often used for symptoms of nausea and bloating like that, should not be used in people with Parkinson's disease, and most neurologists will not prescribe this. The reason for this is because this medication in particular, despite being so common, can actually make the motor symptoms of Parkinson's disease worse, and so we avoid it for that reason.
Thank you so much, Dr. Miller-Patterson. I think Leslie will, Dr. Cloud will move on to our next topic.
Yes, so we're going to talk about maybe some of the more embarrassing symptoms that people don't like to talk about, openly. So let's talk a little bit about genitourinary issues. So we'll start with urinary symptoms. So tell our audience a little bit about what types of problems urinating are common in Parkinson's patients.
Yes. So the most common is nocturia, which just means urinating frequently at nighttime. So having to get up from bed to go to the bathroom. Other common symptoms are urinary frequency in general. So just having to go to the bathroom a lot during the daytime. This is often associated with urgency. So you'll feel fine. You don't have to go to the bathroom. And then all of a sudden you get a very big urge to go to the bathroom and you have to rush. With that, sometimes occurs urge incontinence, which means that you have the sudden urge to go to the bathroom and then you can't quite make it in time. You end up leaking or wetting yourself before you make it to the bathroom. And hesitancy is another symptom. So that's difficulty starting a stream of urine when you're trying to go to the bathroom. That's fairly common in Parkinson's disease, although it's a little bit less common than some of the other symptoms that I mentioned.
And are there treatments for each of those different urinary problems that you just described?
Yes. So for the nocturia, a simple thing, and that, again, that's going to the bathroom at nighttime. One simple thing is just, we encourage a lot of water intake during the daytime to help symptoms like orthostasis and constipation, but sometimes it's good to avoid water right before going to bed because then you might have to get up more frequently at nighttime. During the daytime in general, having like a time schedule, like going to the bathroom during set regimented time during the day can prevent those episodes of urgency and incontinence ahead of time. And so that can be really helpful. And then again, if all else fails and some of those simple, more conservative measures aren't as effective, then we can always move on to medications. So there's a couple of different classes. There's mirabegrins, which is a medication that helps to prevent the bladder from contracting as much, since that's one of the main issues related to urinary dysfunction in Parkinson's disease. And so this is a very good medication that we often prescribe. Another class of medication called antimuscarinics has a similar way of acting as the other medication I mentioned. Some of the medications within this big class of medications we like to avoid, like oxybutynin, since this can cause things like confusion. And so for a lot of people with Parkinson's disease, especially if maybe they already have sleepiness or confusion or things like hallucinations, this is a medication that could potentially make some of those symptoms worse. So you have to be careful about some of the medications within that class, but it is another effective type of medication. And then aside from oral medications, we can often recommend Botox injections. So these are ultrasound guided Botox injections directly into the bladder. So just like we can use Botox for the salivary glands, we can use them for the bladder as well. Most neurologists don't do this themselves, so we'll often refer you to a urologist, so a bladder specialist, to have those injections done if we think that that would be something useful.
And I'll note that those are usually done under sedation, so not
Yes.
to worry, you're not awake for that.
Right, yes.
Okay, thank you for that. So we're gonna end with a final discussion about sexual dysfunction. So can you tell our participants a little bit about what types of sexual dysfunction can occur in PD, and also how do you go about managing or treating those problems?
Yes. So the majority of people with Parkinson's, both men and women, do experience sexual dysfunction. In women, it's often vaginal dryness and difficulty reaching orgasm during sex. For men, it can be erectile dysfunction, so having difficulty achieving and maintaining an erection, and then also difficulties with ejaculation as well. So for women, we'll often recommend vaginal lubricants. Hormonal therapy can sometimes be prescribed as well. For men, erectile dysfunction. So you want to address other things aside from just adding on medication. So if there's a lot of mood symptoms, anxiety and depression, that can contribute to erectile dysfunction. Certain medications like SSRIs, which are often used for those mood symptoms, can also induce sexual dysfunction. So those are things that we want to look for. And again, like with a lot of the other autonomic symptoms, if we can reduce or eliminate or change some of those medications that are contributing to those symptoms, we'll reach out to the doctor who's prescribing them and then try to do that. And then if those aren't effective or not effective enough, then at that point we can consider medications, and we use things like Viagra, sildenafil, which are used for erectile dysfunction in general.
So that wraps up the interview portion of our program, and so we can move on now to audience questions and answers. Thank you so much, Dr. Miller-Patterson. That was very informative.
Thank you.
And we've been behind the scenes collecting questions throughout the program. And I have to say, our audience is very engaged today. We have a lot of questions, and they're really good questions. So we're going to try to get to as many of them as we can. So there's actually a few different questions that all are essentially asking about the time course of autonomic symptoms in relation to the motor symptoms. So how do they change over time? Do they parallel the motor symptoms, and can they occur even earlier than the motor symptoms? So could you comment a little bit on that?
In terms of the time course of the non-motor symptoms related to the motor symptoms, the autonomic symptoms can occur throughout the course of Parkinson's disease. But the types of autonomic symptoms tend to occur at different times. So constipation, for example, and some of those GI symptoms can be very early. So constipation, for example, can even occur decades before somebody develops motor symptoms, which means that people with Parkinson's disease can actually experience constipation related to Parkinson's disease decades or years before they even receive a diagnosis. Again, important to point out that if you don't have Parkinson's disease and you have constipation, it doesn't necessarily mean that it's from Parkinson's disease. Urinary and sexual dysfunction often occur early on as well, and these symptoms can become worse over time, over the course of the disease, but they do sometimes plateau, and with effective symptom management, they don't necessarily always get worse. And then orthostatic hypotension can sometimes occur early, but it tends to develop, the symptoms tend to develop more after a couple of years of disease. And so we usually think of some of the cardiovascular dysfunction as being a more middle to late feature of disease.
Thank you. Thank you. So then we have another kind of cluster of questions that are asking about how the motor medications like levodopa and dopamine agonists impact these autonomic symptoms. And specifically, we had one person ask about how they impact blood pressure.
Yeah.
And we had another person ask about how they might impact heart rate, if they do at all.
Yeah. So levodopa can definitely impact blood pressure. It is a medication that can potentially reduce your blood pressure. And so if you're a patient who has orthostatic hypotension and has symptoms from it, then it can sometimes be somewhat of a challenge to manage those two things. And oftentimes it's getting an effective dose of levodopa or another dopaminergic medication that's effectively addressing your motor symptoms without dropping your blood pressure too much and causing those symptoms. Certain things we can do is make sure that you're taking the levodopa with a meal with a lot of protein, since having the levodopa on an empty stomach can sometimes exacerbate those side effects from levodopa, like the lightheadedness. So having it with a protein-rich meal can be helpful. Sometimes you can add on extra carbidopa, which can help with some of the side effects of levodopa. So carbidopa, levodopa. Carbidopa is a medication that helps to prevent some of the side effects of levodopa. But then again, if you need to be on that higher dose of levodopa, then sometimes we do consider adding on medications to treat the orthostasis.
Okay, great. We have one question about how deep brain stimulation factors into all of this. So does deep brain stimulation impact any of these symptoms for better or for worse?
Yeah, so that's a great question. There is some research looking at this. There's some research suggesting that deep brain stimulation may actually improve some autonomic symptoms. So for example, there's some research showing that it may actually help with some of the urinary issues. That being said, the jury's still out. This is still an active area of investigation. So I certainly wouldn't refer somebody for deep brain stimulation just for autonomic symptoms. It's, again, really something that we use to target the motor symptoms. But it is something interesting. And autonomic symptoms shouldn't be a contraindication to DBS, although one caveat there is that orthostatic hypotension is also very common in something called multiple system atrophy, which is a syndrome or a disease that's related to Parkinson's disease, but different. And people with multiple system atrophy can actually become worse after DBS. And so if that's suspected, then usually we'll hold off on DBS until we're a little bit more sure about the diagnosis.
Thank you. So one participant has asked, does PD cause an underactive bladder? You talked about how it causes overactive bladder, but can it cause an underactive one?
So sometimes, but the vast majority of people with Parkinson's have more of an overactive bladder. Sometimes people with Parkinson's have some hesitancy, so they have trouble initiating a stream. But when you look at the amounts of urine in the bladder, and studies that have done this that have used things like ultrasound, that tends to be less of an issue in Parkinson's disease compared to some other diseases. So for example, I mentioned multiple system atrophy. And so an underactive bladder tends to be more of an issue with multiple system atrophy compared to Parkinson's disease. So for example, in multiple system atrophy, sometimes patients need a catheter to help drain out urine from the bladder. But that tends not to be the case for people with Parkinson's.
Great, thank you. Okay, so one participant would like to know if Parkinson's disease can impact your ability to control your rectum. And so I think what they're getting at with the question is like defecatory dysfunction.
Yes. It can. Constipation tends to be more common than things like diarrhea and bowel incontinence. So it could potentially be related, although if you do have that symptom, again, it's always good to work up other causes of colon and rectal dysfunction. And so this may not just be a conversation with your neurologist, it may be a conversation with your primary care doctor and your gastroenterologist. So you can see sort of the opposite of constipation, so diarrhea and sometimes incontinence, but it tends to be less common than the former.
Yeah. And I will just add a little to that about, it's not as common, but some people with PD don't have slow transit constipation. So things move through their bowel at a normal speed, but they have trouble with the actual physical act of defecation. So the muscles that need to relax and the muscles that need to contract to make that happen aren't coordinated well. And so they feel the urge to go, but they can't actually successfully make that happen. And that can be a difficult problem to treat. But as Dr. Miller-Patterson said, usually by enlisting the help of our colleagues in gastroenterology, or for women, sometimes urogynecology, we can often come up with ways to work on that.
Yes.
And there are other causes other than PD. So in women, obstetric trauma can cause some problems with nerve damage in the pelvic floor that can contribute to this. And so it's not always a PD thing, but it can sometimes be.
Exactly.
All right. So one participant has asked, so you mentioned Botox injections for both drooling and bladder problems. The question is, do those Botox injections have any long-term negative risks or side effects?
Yes. So first of all, you have to get repeat Botox injections. So typically you'll come back every 3 months because the Botox wears off after a while. We'll often use Botox for muscles. And so prolonged Botox can cause what we call muscle atrophy. So the muscles do get smaller and weaker. This is probably a less of an issue with the salivary glands because they're, it's not like a muscle like you're injecting into your neck or into your arm. But it is possible that the salivary glands are less effective over time on their own, and potentially possible with the bladder as well. It's also possible to, but for the most part, patients, the Botox wears off after a while, and patients keep coming back for repeat injections because the effectiveness of the Botox isn't permanent. And sometimes people can build up a tolerance to Botox, so you can get antibodies to the botulinum toxin, so the actual chemical that makes up Botox. But then there are different strains of botulinum toxin. So Botox is a brand name, so there are other strains of botulinum toxin aside from Botox that we can use if Botox becomes less effective.
Great, thank you. So we have a question about nausea. The question is, for nausea, what are your thoughts about the use of Zofran and or CBD/THC products?
Okay, so Zofran can be okay if you're having nausea. That can be an effective medication. Like I mentioned before, the one you want to avoid in people with Parkinson's is Reglan. Because the nausea issue is often the stomach not functioning properly and pumping out enough food into the small intestine. There are other classes of medication, other types of medication that more directly do that. And so that can often be helpful for the nausea as well. CBD, I am not aware of how much research has gone into nausea and Parkinson's disease specifically. Yeah. So my usual response when people bring up CBD for a variety of symptoms is, you can try it. I think, it's something, if you want to give it a try, it's okay. Just be careful because it hasn't been studied in clinical trials. So you might want to pay attention to how much you're taking, start with a low dose, and don't overdo it at first, because there are, even though it's, not a prescription, it is something that could potentially cause side effects. And it could potentially make some of your Parkinson's symptoms worse. So I often recommend you can give it a try, but be careful with the dosage. Just be careful and go low and start slow.
Okay, great. Okay, so we have a very specific question about using machines and devices like a PureWick at night so that you don't have to get up to go to the bathroom, or so that if you should have an accident, it's easier to manage. And the question is, if you use those types of devices, might you be training your bladder to urinate inappropriately? And if you want, I'm happy to just jump in there.
Sure.
So for others who may not know what this is referring to, this is mainly for women. So there's a device called a PureWick, which is available for women, and they wear it at bedtime, and it helps to keep their skin dry. So if they have urinary incontinence during the night while they're sleeping, it doesn't allow their skin to remain wet and cause skin irritation or skin issues. For men, often we will use what's called a condom catheter, which is not a machine or a device. There's no, suction applied. It just allows a way to collect urine that might come out at night without making a mess. So these are devices that are there to sort of not fix the underlying problem, but to make it easier to manage the underlying problem. And I think the answer to the question is probably not, because most people who use them are using them in the event that they were to have an accident and accidentally spill some urine in their sleep, not really to avoid getting up, so to speak. So, I mean, while you can use them that way, I still don't think it would cause a problem with controlling your urine during the daytime, because that would be kind of a conscious choice to use it in that way. So I think it would be safe to use them that way if your mobility is impaired enough that it's not safe for you to try to get up to go to the bathroom at night. I hope that answers the question. We have a few more. Let's see, how are we doing on time? We have a little bit more time. So one person has asked, does PD cause your eyes to unfocus at times?
Yes. So oftentimes, and this isn't necessarily an autonomic symptom, people with Parkinson's disease often have trouble tracking. So there's issues with convergence, for example, looking at a book or something on a printed page and trying to scan across the words. There are devices that can help with this. Sometimes it may be helpful to see a neuro-ophthalmologist to help with certain techniques that can address this. Another symptom that is an autonomic symptom, which we didn't talk about, is photophobia. So this isn't necessarily your eyes having trouble focusing, but what photophobia is light sensitivity. And so if you go outside, you're exposed to bright light, you may have trouble keeping your eyes open and looking around and focusing. This has to do with the fact that nerves from the autonomic nervous system are responsible for how much light the back of your eye is getting by controlling the function of the pupil. So that's another, the bright light sensitivity is another feature of autonomic dysfunction in Parkinson's.
Thank you. So one question is the difficulty speaking that occurs in Parkinson's disease an autonomic symptom?
So no, so that wouldn't be considered an autonomic symptom. That would more be considered a motor symptom. So the hypophonia, so the soft speech is a motor symptom of Parkinson's disease, which we usually lump together with things like tremor and masked facial features and slow movements. And yes, so it would be considered a motor feature.
Okay. And then we have one question about whether Parkinson's disease causes heart palpitations.
So heart palpitations specifically, I'm not aware of. It can cause reduced heart rate variability, meaning that when people are physically active, at different periods of the day, your heart rate tends to increase and decrease. And so in people with Parkinson's disease, just like they don't have that blood pressure regulation, they don't have the appropriate heart rate regulation. And so that can also contribute to some of the lightheadedness and dizziness. But palpitations specifically, I wouldn't say are specific to Parkinson's. And if you're having palpitations, I think you wouldn't just assume that it was from Parkinson's. You'd want to look into other things, cardiac issues as well.
Yeah, I agree. I agree with that completely. Okay, well, I think we have answered all of our audience questions. And it also looks like we're about out of time. So I want to thank, I said that and we got a flurry of other questions. And so we can squeeze in maybe one more. Let's see. Oh, this is a great question for Dr. Miller-Patterson. How would someone become one of your patients? So
good question.
I can answer that. So
okay.
You can call 804-360-4669 and ask to schedule an appointment with Dr. Cameron Miller-Patterson for Parkinson's disease, and they will take care of you. Okay. Well, I hope everyone enjoyed this webinar. And if you did, I hope you'll consider supporting the important work that we do every day in terms of clinical care and research and education. Philanthropic support makes a huge difference in advancing our work in every way. You can learn more about what we do at VCU Health, or you can make a gift by visiting our website at parkinsons.vcu.edu. And I want to offer a special thank you to our partners at Power Over Parkinson's for joining us today and every day on all of our collaborative endeavors. And thank you to the Parkinson's Foundation for their support of this webinar. And as a final reminder, we are recording this webinar and we will share it with you in the coming days. So before we say goodbye, Gary and Margaret, can you tell everybody again how they can find you at POP?
Sure, we'd absolutely love to see you all at our events, exercise programs, etc. And folks can stay abreast of our calendar via our website at poweroverpd.org. And of course, we're also on social media at PowerOverPD. So thank you again for joining us today.